Welcome to this special edition of When Opinions Collide. I'm your host, John Arthur Fiala, and I'm joined by Dr. Bethany Rife. We just had a conversation with Robin Sharon. How are you, Dr. Rife?
I'm doing well. How are you?
Doing all right. I'm glad to have you back. So, doctors have to spin a lot of plates. They have to deal with A, actually taking care of their patients, go figure. B, they have to spend the plate of learning about adverse side effects. They have to learn about vaccines. You told me that you don't get a lot of time to study vaccines in med school, and I mean, who? It's one of the big conversations right now. Uh, and you also have to deal with compliance with all of the paperwork. I know some doctors, probably most doctors that do regular care, they have to spend more time taking care of paperwork than they take care of patients. You mind telling some of my listeners who don't know what it's like to be a doctor who has to take care of all of these? You spend a lot of plates.
Yeah, I think it's even more so when you have a family and that type of thing. So in med school, we're given, we're taught about, here's the medication for this, here's the, how you treat this disease, here's the, of course, we're learning a whole lot of biochem behind that and all the physiology and all of these things. But learning the specific ingredients of every medication that we give, including vaccines, or learning about specific side effects, a lot of these things are left to, that specific physician that you're learning under, or left to yourself to go and research on your own. A lot of medical school is not, here's all the information, we expect you to learn all of this. It's, here are the basic sciences that you need to understand, and here's where to go to find this information, or so that you have the background science knowledge and understanding so that you can then learn these things on your own. Because of course, medicine is so incredibly complicated. The human body is so incredibly complicated. We only understand such a small portion of what the body really does, and and the and then how how we interact with it, as far as our medical interventions goes. So yeah, in medical school, it's not a we're not dissecting every single disease, every single specific medication, every single vaccine. That's not what medical school is for. Medicine is too broad for that. So medical school is so that we can learn the basic sciences and the basic physiology, the basic process of disease. And then in residency, which is the training that we go to after medical school, you learn about your specific field of medicine. So like in my case, I learned specifically about pediatric. And, like an OB-GYN would learn specifically more OB-GYN stuff. And we do all that through in-person, in-hospital patient care, over the next 3 to 4 years. Sometimes some surgery residencies are 5 years, and you go on through training that way. So even in residency, it's, here's the vaccine schedule, make sure your patients are getting these vaccines. And there's not really much else discussed. I suppose in it probably depends on the program, and depends on the specific doctor that you're learning under as to how detailed you get. But it's the same thing with every other, here's penicillin, and here's, all the medical interventions that we do. If your patient has this disease, you do this. And so I don't like to single out vaccines like, oh, doctors learn nothing about vaccines. I don't, we learn medicine in general. And as far as, and, of course, for the medical world, vaccines are totally safe. Of course, every medical intervention has rare side effects. And so that should be discussed. I mean, if we're talking with a parent about, here's your amoxicillin for your kid's ear infection, we need to be saying, like, every once in a while a kid's allergic and gets a rash. And there are a few times where it's such, an anaphylactic reaction can happen. And all those things are on the handouts and those kind of things. So, but the rest of your question was about just everything that we have to do as medical doctors. So where I worked was in a basic small clinic. So I saw between 24 to 30 patients a day. My colleagues that work for the major medical system in the Houston area, they see upwards of 35 patients a day. You schedule patients every 10 minutes. I had patients every 15. But that didn't always work out because then, you force in a sick kid that needs to be seen. So then maybe you need 5 or 10 minute appointments. But we, so every patient interaction translates into about 5 to 10, maybe 15 minutes of paperwork. And so the statistics are that we spend over 50% of our time doing paperwork, just for each patient. And then you're also just, if you're running the business and you're dealing with that information. If you're not running the business and you work for maybe a larger facility, then you're expected to do certain committees. You're expected to do certain continuing medical education things. You're expected to answer phone calls all day long. You're expected to answer maybe email messages or text messages that come through your computer system all day long. And then the typical doctor goes home and probably does 1 to 2 hours more of paperwork to make sure they're caught up on their charts. Our charts have to be done within 24 to 48 hours. And then when you go home, especially women doctors, a lot of us are expected to go home and cook dinner for our families. You take your kids to their sports events, whatever else your family life involves, those types of things. So it's a blessing where I was able to work. I worked part-time, and for me, I actually had a pretty great job situation, but that's not the norm. Most doctors are working 40 to 50 hours a week. They're completely overwhelmed. They're told by their superiors that they're not seeing patients fast enough. Their patients are not satisfied. The patient is not satisfied because they didn't get an antibiotic for their viral infection, and they didn't get enough pain medicine when, that kind of thing. And so they send in poor surveys about the physician. And so, the patients aren't happy because they don't get enough time to talk with the doctor. The staff is trying to get through everything. And so the staff is not happy and too rushed with things. And the doctor's being told they're not seeing patients fast enough and they need to be coding higher and coding, all the coding stuff is ridiculous. And it's just, there's so many hats that we're juggling and so many things that we're trying to keep up with. And basically the physicians are just told on every angle that they're not doing good enough. The physician suicide rate is enormous and very troubling. And we don't have enough doctors in the United States. So, and then we're kind of chasing them out of medicine. I read post after post of physicians that are just ready to quit and get out. They're overwhelmed. They're depressed. Their family life is suffering. They, especially, of course, a lot of mine are from moms. So they feel like they're bad moms because they don't have the energy or the joy to give to their children when they come home because they're so overworked and so stressed and just feel overwhelmed on every aspect.
So, wow. And, you're not the only person who has told this story. There are a lot of people in the medical profession, doctors, nurses, who would say exactly what you're saying. It's not it's not just statistics. Everyone's living this. But the thing that really irks me, especially with some of these debates like vaccines, I did not see this from Robin, but some people end up demonizing doctors. They talk about the doctors and their poison and they're trying to kill me. You hear these people say this stuff and it's like, I'm pretty sure, I'm sure I've met one or two sociopathic doctors out of, I don't know, maybe a few hundred, right? Or a few thousand doctors over the course of my life. Of course, those stick out in mind, but really the jab is not, I don't think it's fair. What would you say to the people who have gripes at folks who maybe prescribe the wrong medication or not the medication they thought they needed?
Well, so I think you have to first understand where the doctor's coming from. A lot of times the doctors are so overworked, and to be honest, doctors become really jaded because we're so used to patients coming in and getting frustrated when we don't give them an antibiotic for their viral infection that when a parent, for me it's parents, because I'm a pediatrician, but when a parent really wants an antibiotic and we don't give it to them, then we get complaints or whatever happens. And so what happens over time is that physician just, the patient comes in, the physician is like, oh, well, mom's not going to be happy unless I give her an antibiotic. I know she doesn't need one, but it'll make mom happy. Here's the antibiotic. We call it treating the parent instead of treating the patient. Uh, so we actually have a name, but it's very frustrating because this is what happens, especially over time with physicians, and and then we make mistakes, especially in adult medicine. Now I don't deal with this much, but in adult medicine, you may have an adult come in with multiple issues that's on 10 medications, and in a 10-minute visit with a patient who complains about something, they've got a cold or whatever, you don't. How are we supposed to also within 10 minutes, get the patient history, examine the patient, go through all of their medical issues and their other medical problems to see if anything's causing this or anything is making this worse, or if anything could be harmed by the medication we're thinking about giving them to help with their current issue. It's just insane to think that physicians, family medicine doctors can do that type of thing with a complicated patient in 7 minutes is what the average patient visit is in family medicine. Like, that's ridiculous.
So how did we get here? How do we get to this point where now doctors are spending more than 50% of their time not with the patients, but just dealing with compliance? I mean, I
Yeah,
understand writing in information and data. However, I know folks who were doing it who were doing the paperwork before we went to all digital, and
yeah.
and all of a sudden they said their workload doubled.
Right. No, the workload definitely got worse when we added the electronic medical systems versus paper. I have a little bit of experience with this because before med school, I worked as a medical assistant for my family medicine doctor, my local doctor, and so she used paper charts. It's so much easier. Because the patient issues that you think are important that you need to know are right there on that front page is the way it was set up. And you could quickly look down the list of diagnoses, and it's set up in a way that's easy for you to read because you set it up. Versus a lot of these electronic medical systems are set up by, computer people who have have no clue how the doctor's brain needs to work in order to make this work. We're getting more and more that are trying to be worked on by doctors, and so maybe that'll help. But really, I think the way we got here really comes down to the insurance companies, and now it's hospital administrators. But the administrators are only there and have to be there because of the insurance companies and because of the government regulation of all this stuff. The way we code for physicians is the ICD-10 codes. Those are how we code for whatever the disease is for the patient. And we send that code to the insurance company, and the insurance company pays based on our coding. That's how it works. And I don't understand the system very well at all compared to some other physicians or people more in the administrative world. But because I hate the whole system. but basically we code, we send it off to the insurance company pays some agreed on percentage of whatever we send them. And it's a mess. And these codes and these things are set up mainly by the government. Well, they are set up by the government. They're set up not by any specific physician or specific even physician-run organization. It's a government thing through Medicare and through HHS and that kind of thing.
So
I,
outside of advocacy, which I mean, I'm a proponent of reducing the legislative bureaucratic chokehold or stranglehold on medicine that's really being I feel perpetrated on you guys. What's an answer in the immediate term because this isn't good for patients. It's certainly not good for
no,
doctors.
right.
How do we get around this right now while we advocate, while we talk to our lawyers? Call your congressman and woman, call your senator, state and local and federal. Call all of them and tell them that we need to have some sort of reform on all of this. But in addition to that, how can doctors and patients find a way through this mess, maybe making it easier on both?
Yeah, so I actually have a great possible answer to that. And there's a movement among doctors to open up our own practices called direct primary care. And you can get all sorts of, if you put direct primary care into Google, you get all sorts of resources. But look for, like, there's DPC Frontier is one of the websites. DPC Alliance has a good, they're an organization of these doctors. But direct primary care is basically a cash pay practice run by the physician. You're paying the physician directly. There's no insurance company involved. Doctors are spending 30 minutes to an hour per patient. Some doctors do home visits. And there's typically, some doctors have one nurse that helps out with things, but sometimes there's no staff. The average in the system physician has 5.5, but 5.5 people per physician to run the office in order to do the phone calls, the billing, all the checkout, whatever every physician does. And that's because each physician has to carry somewhere around anywhere between like 1,500, I've heard up to 7,000 patients per physician. So it's ridiculous. You can't keep track of anybody's name or what's going on with anybody. So as a direct primary care physician, we have around typically between 500 and 600 patients, and we can remember the patient's names. We know their diseases. We know what's been happening lately in their lives. We can just provide better patient care because we know what's going on with the patient. We know their preferences. We know, I remember this mom, she really, needs help, not needs help, but she really likes antibiotics and would like medication. Or this mom never wants to use antibiotics, and if I can help her in any way not use, in any other form to where she can avoid the use of antibiotics, then I know this mom will want that. So let me do that for her. And we can give more personalized care. And I really enjoy it. I'm having a blast caring for my patients. The other thing, most states, now not Texas, which is where my practice is, but a lot of states will allow doctors to dispense medication. So that allows the doctors to buy the medications wholesale. And I've read several stories that the doctors are posting about, I had a patient sign up today. We got all their meds, and they're on, they were using Medicare before and spending, $300 or $400 a month to get their medications, even though they have Medicare that's supposed to be helping them pay for it. And I was able to get them all their meds and for 71 cents.
Oh my goodness.
Like it's that bad. It's that bad. So that's not every case. That's not every med, but it's pretty incredible when we're allowed to do that. We can definitely get meds a lot cheaper, and because we're not paying the pharmacy, we're not paying the middleman to package things, we're not paying. All we're getting is wholesale pills. We're packaging them ourselves. We're putting our own labels on it, and so I think most doctors mark it up about 10% to cover those costs. But it's still, we can buy a bottle of 500 pills for $7, and so each pill is different. Like that doesn't cost anything. So. And it just depends on the med. We have other situations where the medication is super expensive and we can't get it cheap. And we have, there are issues with that type of thing through certain pharmaceutical companies and certain medications that are just expensive, and there's nothing we can do about it. But that's a really cool advantage to direct primary care for a lot of doctors and for a lot of patients.
So what's the disadvantage? You use that one statistic, one physician for every 5 administrative staff effectively. What's the difference here? Where's the drop off? Where's the bad side?
What makes the difference? Well, the bad side of direct primary care. In the end, so from a physician standpoint, you're on call all the time is the way this works. So I don't consider this that big of a deal because I don't have too many problems with it. When you're carrying, somewhere between, right now I have less than 200 patients. I will go 3 or 4 days without hearing from a patient. And then sometimes in a day, I'll get 3 or 4 calls from patients or text. I do a lot of text. And so but it's unpredictable. You may be handling, oh, this patient needs a refill, or, oh, they're having an asthma attack. I need to, make sure that they get their medicine, make sure that they're okay. They don't need to go and get, to an urgent care or anything like that, or I don't need to see them, whatever. So you have there's some unpredictability about it. But in talking with all of these physicians that do this and have, maybe 400 or 600 patients, the middle of the night calls, like 1 to 2 a year, and typically legitimate. Like, you're like, oh yeah, I'm really glad you called. I need to help you with this, or, yeah, I'll be right there, or yes, you need to go to the ER, please go right now. Whatever you can do. The other disadvantage from a physician standpoint, I suppose, as well, or just from a patient standpoint, is I don't own a hospital. I don't own a hospital room. I can't, you still have to use the system for ER services, for, for hospital admissions, for that type of things. I don't do any labs in my clinic just because of the way mine is set up. But that's the interesting thing. Every one of these direct primary care offices is different. We can tailor it to what our community needs, what works for our family, what works for our patients, that type of thing. So it's really nice. But I don't draw labs in my clinic, and so my patients have to go to the lab. I don't, have an X-ray machine, and most direct primary care doctors can't afford an X-ray machine. And so those types of things, these big expensive services, things that really cost money, are a direct primary care physician can't provide ourselves, but we can shop it for you. And so most of them have deals, or at least know the prices of the local places, the local labs, the local imaging centers. Hey, this place has a cash price that, you can get an X-ray over. I know in my hometown, you can get an X-ray for $35. And so, that's fine. So that's probably the biggest disadvantage is things that are actually expensive are hard for us to get. And so really the way insurance should be set up for this is more like car insurance. You have car insurance for when an emergency happens. And that's how health insurance should be. And then the rest of it, and then health insurance could be cheaper. And all of your basic things, your well visits, your, basic meds, your basic things that you need are you just pay cash for, because that's not that expensive. And so it makes a lot more sense to pay for it that way.
I mean, it sounds like you're actually paying for what you're using.
Right. So most direct primary care physicians are set up on a membership base. So you're paying monthly. And that means you can call and text your doctor whenever you need. And it works out because each individual person may go 2 or 3, 4 months without contacting the doctor about anything. And then you may have a month where, I'll have a patient that's going through ear infections. And so they're calling me every week, and I may see them in the clinic several times or something like that. And, but then I won't hear from them for 6 months when their ear infections go away. And so it kind of evens out and levels out, and we make it work that way. And there are other doctors that do it just based on visits, like that you just pay cash when you come in. Every time you come in, you pay cash, that type of thing. In the end, I think that actually comes out typically more expensive if you use the doctor frequently, or at least a few times a year. I have a lot of patients that talk with me, and they're like, well, my kid never gets sick. We go to the doctor maybe once a year for a well visit or that type of thing. Then fine, pay for your well visit. And I'm okay with that. A lot of direct primary care doctors want to be pure direct primary care. So you either sign up or you're not my patient kind of thing. I prefer, because of just my community and the type of patients that I carry, I haven't ended up with a lot, because once they do the math, they realize it's really not that much more expensive just to be a member. But non-members, just paying for their one well visit a year, fine. And that works well too.
So, where can people reach you? And if not you, where can they reach a primary care physician if this sounds like a match for them?
So direct primary care, the DPC Frontier has a mapper. And so you go to dpcfrontier.com/mapper, and that'll give you a map for your area, and you can look around and see if there's any in your area. There's also like use Facebook and find the direct primary care doctors on Facebook in your area. For me, my website is rifepediatrics.com, and Rife is RIFE, and I'm really in the Houston area of Texas, and I want to see patients about once a year in office. So I don't mind if you live somewhere far away and you want to drive to Houston for that one visit. And then I'm licensed in Texas and Alabama, so I can see anybody in those two states. So that's how my practice works. And the website gives you more details about how my individual practice works. And like I said, all of these practices work a little bit differently for whatever their community or what works for their family. And it works really well.
Dr. Rife, thank you for coming on. I appreciate your time. Hope to see you again.